Good afternoon. Welcome to our Law Alumni Weekend 2020, a virtual conference. Thank you for joining us for today's conversation and CLE on the legal and societal ramifications of COVID-19 on marginalized populations. My name is Fulvia Vargas de Leon, and I am a class of 2015 graduate of the College of Law. We have a sizable audience here today. We have about 50 participants so far, and we're expecting a couple more. We are in webinar mode, which means that the audience can hear and see all of our panelists, but the audience is not on video and it is muted to prevent noise interference. However, we welcome all your questions. Please use the Q&A pod to send them along. It is located towards the bottom of your screen. We will monitor the board and include them in our discussion as much as possible. Please note that the chat feature has been disabled, except to convey universal guidance to all of you during the program. Please also know that we are recording our session. That recording will be available on the College of Law's website. We want to thank our CART reporter, Linda Frost, for her services today, and our live captioning sponsor, the Waldes firm. Any member of our audience can view instantaneous translations of the spoken language during the program by clicking on the closed caption button at the bottom of your meeting window. We are here today to begin a discussion about the disparities that exist among Black and Brown communities in their access to basic needs such as healthcare, education, housing, and employment. Today our topic of focus is the legal and societal ramifications of COVID-19 on marginalized members of our community, with a particular focus on elderly populations. We know that COVID-19 has disproportionately impacted Black and Brown individuals. However, we know that COVID has simply just brought to light the inequities that already existed in our communities for decades. Now is the time to take a step back and not only understand the systemic conditions that resulted in these communities being the hardest hit by the virus, but start building policies and practices that can adequately address the needs of these communities. And we'll start by first introducing all our panelists. We have Dr. Sharon Bragman, Professor Nina Cohn, and Dr. Daryl Dykes. Dr. Bragman, could you introduce yourself and tell us a little bit more about your experience with this topic?
Hi, my name is Dr. Sharon Bragman. I'm a distinguished service professor at Upstate Medical University, and I am chair of the Department of Geriatrics. I also direct a Center of Excellence for Alzheimer's disease, and my interest in aging obviously has been the focus of my whole career, but I've also been interested in the intersection of ethnicity and race with aging. And I helped start a committee with the American Geriatric Society called the Ethno-Geriatrics Committee, which was part of our national organization and still exists. And I helped to write some books and guidelines to help geriatricians become culturally competent. So this has been my background for the extent of my career.
Thank you, Dr. Bragman. Professor Cohn.
Hi, I'm Nina Cohn, and I have had the pleasure of being many of your professor over the years. So I'm looking at the names in the participants list, and it is such a treat to have you back with us. It is really an honor to be speaking to you now that you're on the other side of this divide. Although I will point out that we do have some current students on with us too, which is good. Ms. Vargas, do you want me to say more now or just introduce?
You can go ahead.
Okay, so amid COVID, it's been a very interesting time for me in my work because, as many of you know, my work focuses on how the law shapes the aging process and responds to it, and it both increases and decreases our vulnerability as we age. And COVID has done a tremendous amount to expose how the law affects our vulnerability as we age. We know that older adults are more susceptible to COVID because their bodies are more susceptible to a severe reaction, but we also know that the extent of infection among older adults we're seeing and the degree of COVID-19 related suffering we are seeing are not foregone conclusions, but rather the result of political and social choices about how we value and how we care for older people in our society. And I've been looking a lot at long-term care facilities, and as many of you know, it's looking like about 40% of our fatalities coming out of COVID-19 are from long-term care facilities. And one reason for that is we know that these have long been infection tinderboxes, and that dangerous conditions have been accepted in nursing homes. Even if you look at nursing homes given a 5-star rating by the federal government, more than half had recent infection control violations. And yet enforcement actions against operators have rarely amounted to more than a slap on the wrist. And the U.S. has never, for example, imposed the minimum staffing levels that are agreed by experts to be necessary to keep residents safe and avoid systemic neglect. And indeed, the federal government's reaction to COVID-19 sweeping through nursing homes has not been to enforce existing standards, but rather to increasingly waive those standards and provide immunity to nursing homes for violations. So, you know, that's just one example of how some of the suffering we're seeing among older adults reflects what I think is really a devaluation of older lives. But for this panel, I think it's also really important to point out that it's not just a devaluation of older lives, but it also reflects a devaluation of the workers who are providing the direct care in this environment. So low pay, we know, leads many direct care workers to hold multiple jobs in the long-term care industry. Lack of sick leave and benefits means staff come to work when they're sick, and so staff become ideal vectors for the virus. And one thing then that COVID can expose for us, I think, is that the interests of direct care workers and care recipients are more aligned than perhaps typically acknowledged. You know, we often are told, well, we can't pay workers more because elders need affordable care. That if workers get benefits, that's going to take resources away from older adults. But what COVID-19, I think, shows us is that policies that put direct care workers at risk also put older adults at risk, right? And that the structural racism that has contributed to a marginalized and at-risk economy of care is now also contributing to the death and suffering of those to whom care is being provided. And indeed, for those of you who like following this dialogue, you may have seen, I think it was last week, a study came out that really surprised people, showing a pretty strong correlation between COVID-19 infection rates and unionization in nursing homes. So unionized facilities having safer conditions for residents. So I'll stop there. I wish it wasn't taking a crisis to get us talking about this, but maybe it provides an opportunity and we won't let this crisis go to waste.
Thank you, Professor Cohn. Dr. Dykes?
Yeah, thank you for the invitation, and thank you all for joining today. It's a pleasure and honor to be with you. Just quickly about myself a little bit. I'm a Syracuse native, Syracuse University alumnus, 1988. Stayed here in Syracuse at Upstate Medical University for my medical degree and a PhD in molecular biology. Kind of went on to do training in orthopedic surgery. Now on the faculty at Upstate as an orthopedic spine surgeon with a joint appointment in our Center for Bioethics and Humanities. I'm also a law school graduate. Finished my law degree in 2015 at William Mitchell in Minnesota, and then went on to serve as a Robert Wood Johnson Health Policy Fellow in Washington, D.C. So in my time in D.C., I worked for the United States Congress and the Committee for Energy and Commerce, which doesn't sound like it has anything at all to do with healthcare. But in fact, it is the majority committee in Congress responsible for over 90% of the legislative and oversight activity in healthcare. During that time, I worked primarily on the 21st Century Cures Act, which you might be familiar with. It did have some provisions with respect to health disparities, and then also FDARA, which is the Food and Drug Administration Act of 2021. So my research and activity now that I've been back at Upstate and for the last 10 years has really been on health disparities and primarily the legislative, regulatory, and policy levers that either contribute to health disparity or serve as potential tools to remedy these disparities. And then finally, I'm now the Chief Diversity Officer at Upstate Medical University. So that takes a lot of my time in looking at these issues pretty closely.
Thank you, Dr. Dykes. So let's begin our discussion by speaking on the health issues that existed in Black and Brown communities prior to COVID-19. Could Dr. Bragman, Dr. Dykes, could you speak about the health disparities that you saw prior to COVID-19 in these communities?
Well, it is very clear from our historical basis that we know that just about every disease category has increased prevalence or severity in people who are Black or Brown. And that's not because there's a genetic predisposition. I think most of the history in our country has been trying to find a genetic defect that makes Black and Brown people have these diseases. We know that race is a social construct, and the basis of racism is controlling people, controlling or preventing them from having access to things that keep you human and healthy. So if we look at that in a general perspective, you can understand why in Black and Brown communities there are more health problems, and it really affects every organ system. There's increasing research that shows that racism in and of itself is a healthcare problem, a public health problem. And there is increasing research that shows the chronic stress of discrimination and poverty actually causes chronic inflammation, the increase in stress hormones in the body, and these things lead to things like hypertension, heart disease, diabetes, obesity, increased dementia, and other things related. We also know there's a huge wealth gap between white and Black and Brown communities, and we know there's a strong correlation between socioeconomic status and health. And that could be because of the job you have. The job you have often leads to benefits that then leads you to good health care. But even when you control for insurance, when Black or Brown people go to a hospital, they get different care. So this is not just an economic issue, this is also confronting the racism that's prevalent in medicine. And so therefore, if you go to the hospital with pain and you're Black or Brown, you're not going to get the same treatment for pain. Some people said, well, that's a benefit because maybe there is less opioid addiction in Black and Brown communities, but there isn't. When there was a drug addiction in Black and Brown communities, it was criminalized. It wasn't considered a health problem. So every disease state has that implication and that overlay of race, and that's what makes everything worse. Now, I'm not in OBGYN, but many of you have heard about the increased risk of death or complicated pregnancies in African-American women, and this is regardless of their insurance or their socioeconomic status. We know that pregnancy is a very high stress time on the body, and then if you layer on the stress of dealing with discrimination or maybe not even being heard or taken seriously by your doctor, you can see where this starts to have implications for bad outcomes. So none of these have simple point A to point B answers. There's many, many layers and many, many different approaches. And then of course, when you look at geriatrics, these are people who tell me stories of growing up in segregated Florida where they had to hide in a ditch every time a car went by because if it was white people in a car, they could get killed or raped. And they did not get health care. They did not get education. So when they come up here, and even though they've been in Syracuse now for 50 years, they have low literacy. They have low ability to understand and read drug labels, so they could take meds wrong. So you can just see all the different layers that you have to start to peel away if you want to take care of people in a way that really meets their needs. Another example that I worked on earlier in my career were the tests that were used to screen people for cognitive impairment. These were tests that were done in well-educated, primarily Caucasian communities, and there were inherent biases in these screening tests that could make people look like they were demented when they really weren't. So there were educational biases, there were social and cultural biases, and this has eventually led to the development of screening tools for cognition that have reduced biases. So you can pick any organ system or any disease state and start to deconstruct the pieces where racism and socioeconomic status can play a role.
Thank you, Dr. Bragman. Dr. Dykes?
Yeah, so actually I concur with everything that Dr. Bragman said. I think one of the other important things to recognize is not only the fact that these health disparities exist, and they exist very, very clearly, and they've been pervasive and persistent. They're deeply baked into our system. And so it was 2003, just 17 years ago, when the Institute of Medicine, now the National Academy of Medicine, published their landmark report called Unequal Treatment. And this was the first real recognition, formal recognition, although we all knew it happened, of the tremendous impact of health disparities in the United States. And as Dr. Bragman mentioned, this report for the first time demonstrated that even adjusting for socioeconomic factors, there were widespread disparities in healthcare across several groups. Some of the anecdotes and reports that were particularly revealing to me, there's actually a report, as an orthopedic surgeon, there's a report that African-American patients who present to emergency rooms with long bone fractures, these are fractures of the femur or tibia that you can actually see on x-ray, there's no way to fake these injuries, actually receive disparate pain medication in their emergency room experiences. So when you dig deeper into this issue, and this has been a focus of my work over the years, is understanding not only where these disparities exist, how they manifest, but why they exist and why they have occurred. And one of the things that is very clear is if you look back historically, even to the turn of the last century, there was very prominent work that was published by a statistician and very prominent economic statistician at the time named Hoffman. And Hoffman published a report that attributed the disparities in health and death that was apparent around the time to inherent race-based differences between Blacks and whites at the time. And so this theory actually prevailed in the insurance industry for almost 30 years. And African Americans were denied access to hospital care and to insurance coverage and health insurance and life insurance for 30 years until additional work came along, largely conducted by W.B. Du Bois and Booker T. Washington, that actually showed clearly that it was socioeconomic factors, not inherent race-based factors, that was responsible for, could explain these differences in health and mortality. So again, 100 years of these traits that have been baked into our system, and there are countless examples along the way that show very clearly how from a systemic and policy level, there have been actions or lack of action that have baked these disparities into our system. Finally, I'll say that despite this unequal treatment report that was published 17 years ago, if you look at the statistics around health disparities and the tremendous effort that has been dedicated to eradicating health disparities, we have barely moved the needle. In fact, in most instances, we've regressed in terms of the care and the disparities that were evident almost 20 years ago. So I'll stop there as well, and hopefully, through the rest of the conversation, we can dig deeper into some of these factors.
Thank you, Dr. Bragman and Dr. Dykes, for highlighting these issues. And now So we know that these issues are very systemic and so ingrained into our healthcare and our practices in the medical and probably the legal field in terms of the policies that come out to address these, or they do not address these health disparities in our communities. So now we're in this COVID crisis. Can you tell me a little bit more about your experience and what you have seen now that COVID has hit these communities? And although we are well aware of these disparities, what do you think COVID did differently in its highlighting or its impact on these communities?
So to me, it has just highlighted the extent of my career where I spent so much time trying to show people the importance of aging and providing good care and valuing older people. And this virus just laid that all bare. I was just talking to a colleague last night who said, essentially, we don't care that old people die in nursing homes. So I take care of patients in nursing homes and assisted livings that got shut down, no visitors. I take care of older adults at home who just suddenly got cut off. These are people that do not have high-tech skills, so they can't jump on Instacart and order groceries. They can, if they have grandkids, then we're golden, but other than that, they often have landlines and wall phones. Maybe they'll have a flip phone. So they got cut off on many different levels. And that isolation is just as deadly as the virus. So I had patients who had the virus and then patients who didn't have the virus, but they had collateral damage from the isolation related to the virus. It was also very clear that no one wanted old people in their hospitals. There was, as Professor Cohn says, as we get older, it's harder for our body to fight these infections. And it was very clear that if an older person was put on a ventilator, they would not do well. So there was no desire at all to have these folks transported to emergency rooms. So that means they were either in the nursing home or they died. But concurrently, there was no supports for them in these settings for them to get the care that they needed. Many nursing homes did not have protective equipment. There were no masks. There was no testing. They would call 911 and the 911 wouldn't even come and pick up people who had passed away. So then they started to have problems disposing of bodies appropriately. I had a patient at home who lost 15 pounds in the first 2 weeks of the shutdown because she could not get groceries and she couldn't get someone to come and help her. So we had huge, huge issues. On the other hand, I also have adult African-American patients who heard very clearly that they were highly likely to get this disease and that there was a shortage of ventilators, and they knew very well that they would not get one. So they were petrified. They did not want to leave their home. The message was very clear. If you remember the early days of the shutdown, there was even a prominent politician who said, well, old people wouldn't mind dying if it meant that they would save the economy for their grandchildren. And so it was painting people over the age of 60, which isn't really technically geriatrics. In geriatrics, I tend to take care of people who are in their 80s and 90s and beyond. 60 is not old at all. And I mean, I used to think 60 was old, but it is not old now. But to hear them on TV call people who were 60 geriatrics and essentially write them off as though you were one homogeneous lump. So I have 85-year-old patients who have no cognitive deficits, they're functionally intact, they're volunteering, they're active with their families and their communities. I also have 95-year-old patients with advanced dementia who need total care. But everyone is different, and you can't just lump everyone over a certain age into one category, but that's what was happening. So that is some of the indications of ageism. The other thing is that we did not even count older people correctly. And as Professor Cohn mentioned, about 40% of the deaths due to COVID are from nursing homes. But that information has not been counted well, and I wouldn't be surprised if it's higher. And recently, all of this data have been manipulated because current leadership does not want accurate counts. But all of my colleagues across the country think that the toll on older adults is going to be much higher when this is all said and done, and that we will have essentially eliminated a good slice of older adults in this country. And that's someone's mother, that's someone's father. You know, I get a lot of converts when somebody's mother gets sick. I always say, everyone has a mother, right? And so you can wash your hands of older people until it hits you at home, and then you want good care for your loved ones. And we have not been giving good geriatric care in general in this country, and this became even more evident during COVID. The other thing is that nursing home care, again, as Professor Cohn mentioned, has never been ideal in this country. It's been warehoused, under-resourced. 70% of nursing homes in the United States are privately owned. And so they know how to squeeze every dime out of the care to make maximum profit. And that usually means less than adequate care. So I hope out of this pandemic, if there is something nice, we radicalize nursing home care. Nobody wants that old hospital setting with a roommate. Roommates are overrated after college. Nobody after undergrad really wants a roommate, and you certainly don't want one when you're geriatric and you have dementia. So we need a smaller scale, more home-like settings, more personalized care. But most of all, we need to look at how we're financing care of older adults.
Dr. Dykes.
Yeah, I won't say a whole lot more about that. I think Dr. Bregman, precisely covered all of those grounds. The only thing that I might add is that there's a particular subset of the elderly, the so-called dual eligible. So these are people who are not only old, but they're poor. And so patients who are Medicaid and Medicare eligible, and CMS has, CMS Center for Medicaid and Medicare Services has published some very compelling and disturbing data that particularly for this population, the older folks who are also poor, this has been particularly devastating.
Professor Cohn, I'd like to loop you in. I think it's shocking for most people to hear that there are hospitals that can decide who gets a ventilator, who gets the best treatment. And I just wanted to loop you in here. And what are some of the things that people can do now to stand up against these unsafe conditions and the treatment of the elderly?
Well, I mean, the good news is that pretty much everyone here has a law degree, right? So you are exactly the right people to be making change here, because a lot of what we're seeing are policies that don't work, either because they're the wrong policies or because they're not enforced. So let's say, hypothetically speaking, you're a prosecutor. There is work for you here, right? So the other day I was talking with an ER doc telling me about just the horrible cases he sees coming into his ER from nursing homes, and really despondent about how sad it was. Every case he was telling me about was probably a crime. Every case. But he doesn't know that. And he's not sending them to the police, and he's not prosecuting it, helping you prosecute it. So it's really important that when people are being criminally neglected, when people are being abused, that law enforcement treats it as such, right? And that has a trickle-down effect when you do that. Even if you're just bringing one case in your jurisdiction, right, that can make a difference. If you like suing people, this is your moment, right? A lot of what's going on is illegal, right? A lot of it is a tort. If we think about, for example, what we're seeing in long-term care right now, and I'll go back to what Dr. Brangman was pointing out, is that 70% of our long-term care facilities, our nursing homes, are privately owned. We know that private ownership status is a predictor for poor care. Why is that? Very simple, profits above people. And the good news is if you like to bring lawsuits, especially if you're in New York, these have historically been really viable cases. Now that said, right, what's happening right now is we're seeing states around the country granting broad legal immunity to nursing homes. We see the SAFE Act before Congress that would grant 5-year immunity to nursing homes and healthcare providers for anything COVID related. Let me just harp on this 1 second, right? Because this is something that you can all do something about today, right? 5 years. COVID related means any way you might restructure your resources because of COVID, right? So you're a hospital, you decide to take people out of OBGYN because you're repurposing it. As a result, you have women dying. That's COVID related under this act, okay? 1-year statute of limitations, you basically need an expert opinion even to file the claim. Only claims for recklessness are gross negligence are allowed, but gross negligence and recklessness is defined in a way that if you had defined it that way on my tort exam, I would have laughed because it has no bearing on the common law standard, right? Completely made up rule for gross negligence and recklessness. But people don't understand this. And why don't they understand the impact? Because they don't really understand how our legal system works. So think about the public education you can provide in your own community, talking at events. Lots of people are hosting Zoom events right now. Talk to your local hospital about what standards are. Talk to your, that can also, you can make connections for your own practice at the same time providing some really valuable education. And then I think there's a lot of room for advocacy here. And then there are things that people agree upon, but they don't know how to do, right? So, we know that part of what we're seeing in terms of this sort of perfect storm for older adults who are Black and brown is that we have these two identities colliding, both of which create vulnerability. Then the vulnerability is enhanced because of socioeconomic factors, which are themselves shaped by structural racism. So think about the policies that might change that. So one thing, right, we might think about is just something as basic as social distancing, right? Amid COVID-19, we're all told to social distance, which is great, but it's a unaffordable luxury for many people. It's not a realistic thing to ask many people to do. It's not an option if you're working in a lower paid position in the service industry for most people, if you want to keep food on the table. That disproportionately affects people of color. It's not possible if you're living with family members in such positions, as is disproportionately the case for older adults who are brown and Black, right? We know, for example, that individuals who are Black are about 60% more likely to live in a multi-generational household than those who are white. It's not going to be possible if you're actively grandparenting young or school-age children. And we know that Blacks are more than twice as likely to live with their grandchildren as non-Hispanic whites. And that reflects a lot more than simply values and preferences. It reflects poverty, it reflects housing instability, it reflects patterns of incarceration, it reflects a lack of family leave. And so, I encourage people who are in their communities to think about what policies could you bring people around together. There is incredible power in a drafting exercise, whether that be a local ordinance or a state law. Sometimes people think they're at very different places because they're coming from different worldviews, but when it comes down to brass tacks and actually putting language on paper in the form of a statute or a regulation or an ordinance, they can find more overlap and agreement. So I guess what I'm saying is prosecute, sue, and engage in law reform and engage in education and use your ESQ to do that.
Can I add something to that? So actually, I'm going to show you this cover. This is a law review article that I authored about 5 years ago. I did not put it in the reading list. I think the most useful purpose for this, I prescribe it to my patients who have insomnia. But But otherwise, it was kind of a pretty painstaking and thorough look at all of the impacts from constitutional law through tort law, federal, state, and law, and even the most recent Affordable Care Act on health equity issues. And one of the things that Professor Cohn mentioned that I want to sort of pick up on is even tort law has been hamstrung significantly from a disparities perspective, right? You can bring a cause of action for general negligence in a nursing home, for instance, but that affects nursing home care in general. It still doesn't get to why is there disparate impact, disparate effect on these minority populations. And if you look at a series of very carefully crafted court decisions over the years, a couple things have happened. Number one, there is no private cause of action for disparate impact in patients who are receiving, healthcare. On the other hand, those cases are pursued generally by the Office of Civil Rights at HHS. And if you look historically, there has been almost zero log of cases that have been pursued by Office of Civil Rights for racial and ethnic disparities. The majority of those cases are pursued for, not providing language translators or other things like that. So even under tort law, there's very, very difficult. It's very difficult to get at this disparities issue. And then where there are resources at the federal government, they just seem not to be pursued.
Thank you, Dr. Dykes. I actually was not aware of that. And it's interesting when we talk about even nursing homes and the potential immunity that these nursing homes are going to receive or may receive in the future. For 5 years seems like a very long time to receive immunity. I was wondering, was there any, I guess, at the start of this pandemic, was there any oversight that nursing homes were under, or any agency that did provide oversight for nursing homes? Because I understand that they're private, but it seems shocking that no one was going in to still investigate during the pandemic what was going on and how this was impacting Black and Brown communities.
Well, I mean, nursing home law is actually gorgeous. Right? I mean, if you were a patient advocate and you were writing the law, it would look a lot like this. The issue is not the law, right? It's the gap between what's happening and what's on the books. So surveyors go into facilities. They do fairly thorough investigations. We could quibble about how that works and the predictability of the investigation and yada, yada. But here's the big issue. These investigations typically don't have teeth, because the penalties for violations are so meager that in many cases the best business decision is to just not worry about it. The fines are low. Under the Trump administration, there's been a major cutback in the fines and the way the fines are levied, going from per day to per incident. And so this is where you really need law reform to a degree, but really law enforcement, because the federal government has really abdicated its responsibility to meaningfully enforce what is a pretty decent set of statutory and regulatory guidelines. And that's why, when people on this call say, well, what can I do? It is to provide that additional enforcement. These cases may be hard to bring in an atmosphere where immunity is being granted, right? These cases may be hard to bring. What you're really trying to get at is a racial disparity. And so, we don't usually think of negligence suits as pro bono cases, but you might want to think about them in that way in some of these cases. Can this be your pro bono work? Can this be your public interest work? Potentially when the going gets tough.
But I would also like to say that this is not all nursing homes' fault too, because having worked in just about every nursing home in Syracuse, there is a whole perception of aging and what older people need. The nursing home is so overregulated sometimes that you can't even take care of the patient because you have overwhelming paperwork to fill out. And the people that they hire are often single women who are making $14 plus an hour. They often have to work more than one job. They have to do a job that nobody in this audience would ever want to do. You could work in the mall and keep your hands clean and get your weekends off and get a store discount. This has to do with how we decide to take care of older people. And this is an example of how you can have a gazillion regulations, you can have a beautiful chart and a dead patient. You also have to realize that most of these patients are in a phase where they are approaching the end of life. And what they really need is good palliative care. And a lot of these facilities only get reimbursed at a higher level if they get rehabilitation. So there's a perverse incentive in most of these nursing homes to accept people for rehabilitation. And most of them don't have any rehab potential, but they're in there for rehab because Medicare will pay for rehab and Medicaid pays for straight medical care. What we also have is a huge denial about aging and the end of life and the burden of chronic disease and what is the reality of it. Most people who are admitted to the nursing home are going to die there. And dying is not necessarily a negative. So we have these regulations that seem to make nursing homes magically think they're going to make people with chronic disease better. And when they don't get better, it must be the nursing home's fault. So that's not to say there aren't staffing issues or other things, but I think there is a real denial about the aging process, what the end of life looks like. 99% of the people who are admitted to a nursing home have Alzheimer's disease, and advanced Alzheimer's disease is the equivalent of having metastatic lung cancer. It's a terminal event that has pretty well documented impacts on the body. So that we have somebody who is likely dying, but then we put it on the nursing home to keep them from dying and keep them healthy and rehab them. So this is a perfect storm between our denial as a culture about aging and the end of life and a regulated environment that's often so punitive. You can't have patients get the care they really need because they have to follow a lot of regulations. And I've seen this happen on so many occasions because you can't have this because this is against state regulations. So here's an example. At the end of life, a lot of people with Alzheimer's disease stop eating. But if you document weight loss in a chart, that creates a trigger, and the nursing home could get penalized for having patients who lose weight. But weight loss is actually a natural process at the end of life. So what do nursing homes do? They tell families that someone is losing weight, they need a feeding tube. We know that feeding tubes actually increase morbidity and complications, and they don't change the endpoint. But if you have a feeding tube, then it looks like you're trying to make sure that patient will gain weight. So it creates these unrealistic goals, and we can't always say that this is just the nursing home's fault. This is our cultural denial about the end of life and what it looks like. Most of us get our information about the end of life from television. And one of the shows I love to hate is Grey's Anatomy. I used to watch it because I had a geriatric aunt who loved the show. And they would have there was a scene on there where the head woman, I can't remember her name, but she fell in the ice and she was submerged for 45 minutes and Dr. McDreamy saved her. And he pulled her out and he takes her to the emergency room. And of course she's beautiful and the emergency room is clean. And she goes immediately into one of these nice, well-appointed rooms. And she's flatlined, but they shock her. And you never shock a flatline, but it's dramatic. And they shock her and everybody stands back. And lo and behold, she comes back to life. Her brain works, she's beautiful, and she goes to work the next day. So what do you think my chances are when I go to talk to a family about their 95-year-old grandmother and whether or not she should be resuscitated? they think of Grey's Anatomy. And then if they don't get a perfect outcome, they think it must be someone's fault. And that's when I would have to say, this is not the nursing home's fault. The nursing home is taking care of someone at the end of life. It very rarely looks pretty, and it usually ends in death. Pressure sores, that's another example. Pressure sores have been relegated as an indication of bad nursing care. But we know that the skin is an organ. It's the most visible organ we have. It's the largest organ, and it reflects the health of other parts of the body. So when your brain is dying and your heart is dying and your kidneys are dying and you have bad lung disease, your skin breaks down too. It doesn't always mean bad nursing care. So I just want to make sure that we're not just making the nursing homes completely the bad guy, because I know a lot of nursing homes that try to really provide good care, but the Medicaid reimbursement for nursing homes is really low. They get a set dollar figure a day, which barely covers staff, does not cover most meds, and does not add to a nice, beautiful environment where somebody would want to be in their final days. So this is based on how we decide to use Medicaid dollars. And we fall for that misinformation that Medicaid goes to single Black women who are irresponsible and have multiple kids, when Medicaid is actually the largest payer of old people in nursing homes. And that is the truth, but it doesn't get the same kind of publicity because we write off old people all the time. So I think that if we want to improve nursing home care, it can't just be from a punitive perspective. It also has to become part of our understanding about what happens at the end of life, what's realistic when somebody goes to a nursing home with advanced dementia, and how do we get those workers on board. I would go into the nursing home and the workers would come and tell me that Mrs. So-and-so doesn't look right. This is supposedly an unskilled person who shouldn't do anything unless they speak to a registered nurse. But I know that they know this person really well, right? The registered nurse is often somewhere else with her clipboard in a meeting. So when these nurses' aides would come and tell me that Mrs. So-and-so doesn't look well, and I would go in, I would take their word for it, and sure enough, Mrs. So-and-so didn't look well. And that's from the unskilled worker who's making $14.50 an hour. So there are many layers here, and I think it is very easy to just blame it on the lack of regulations, more regulations, nursing home. I mean, that's all part of it, but again, it is much more complex than that. And I know some nursing homes that are trying to make a difference. Some of them can't even make ends meet. They end up getting bought out by these big venture capitalist nursing home companies. We had a public nursing home here in Syracuse, Van Dyne. Public for the citizens of Onondaga County, could not financially make it. The county sold it to a private industry. So what law is that? What law could have prevented that to keep that a public nursing home?
Thank you, Dr. Bragman. I'm going to direct this question first to Dr. Dykes, just to get your perspective. What would you say are 3 or less policy initiatives that the panel should think about, that everyone should focus on in terms of a medical perspective and from a legal perspective? I know you have this policy background, and I think it's helpful to hear your thoughts on that.
Yeah, I think, well, obviously, and you all know well that outcomes are affected at the, legislative, regulatory levels. I think, as Dr. Bragman, just pointed out, there are a number of regulatory issues that certainly have unintended consequences at times. And so I think that that's an area that is, ripe for study and debate and advocacy. And it's the same with on the legislative side. We all know that, again, some of the protections that were baked into the Affordable Care Act, specifically with respect to health disparities, have been whittled away through various executive orders and court decisions over the years. There's another one pending that may make all of this moot. But I think the other policy issue is we can recognize and advocate for sound legislation, sound policy. I think if there are specific issues to be addressed, and again, this reflects some of Dr. Bragman's comments, payment reform is something that is very clearly an issue when nursing homes or healthcare providers can't even keep their lights on at the rates that they're reimbursed for providing care. It becomes an access issue. And we understand that access is absolutely the cornerstone of a lot of these disparities. So I would say, common sense, regulatory and legislative reform, payment policy reform. And then I think the other thing that really needs to be addressed is just the complexity. And the healthcare, the intersection between healthcare and health disparities is incredibly complex. And actually, I'll just very quickly to show you one more picture here. This is a diagram of just the federal healthcare landscape as it reflects health disparities. And you can see that health disparities is that stop sign looking box there, the octagon box or hexagon box there. And all of these federal law, state law, health and human services, international law, all feed into this. And it's a very, very complex system. So I think the other thing is we need sort of common sense reform of the health equity machine in Washington. And there has been some effort to do this. A lot of those efforts sort of went dormant over the past several years, but that's something that needs to be focused on again.
Thank you, Dr. Diggs. Professor Cohn?
Okay, so 3 things. I think first, we need to focus on providing more payment for long-term care in non-institutionalized settings, which means eliminating rules and systems that give preference to care in institutionalized settings. So, for example, making sure that people who can have their needs met in a community-based setting can get that care, and not capping, for example, access to Medicaid provided long-term care in the community to a certain number of people. Again, to go to the ESQ behind your name, right? In many cases, that probably actually runs afoul of the ADA. So a great thing to sue about. Another thing is tying payment to quality of care. I must admit, I'm a bit frustrated and not amused by the claims of poverty from the nursing home industry when we keep being asked for more taxpayer money and not tied in the least to quality of care. It may make sense to increase reimbursement, but that should be tied to either quality measures as opposed to just paying for a number of days you manage to keep someone alive, irrespective of the quality of their life, or B, inputs that we know make a meaningful difference in quality of care, like direct staff time. And then the third thing I would say, if we're trying to reduce disparities and increase quality of life, is to support families that provide care and to focus on policy changes needed to do that. And I think that means funding paid care, paid leave for care. That means broadening who can qualify for family leave so that we're recognizing family systems that reflect a broader range of family structures in America. For example, grandchildren providing care is very important for many communities, and yet grandchildren are not covered under the Family and Medical Leave Act, except on this very teeny exception. And then we also need to focus on not penalizing families that do provide care. So for example, the way Medicaid eligibility for long-term care works right now. Older adults who have paid a family member to provide care for them risk losing eligibility for the nursing home or home and community services based benefit, because that payment to the family member, which may be essential to the family system providing that care, often looks, because of the way regulations are written, as a transfer for less than fair market value. And so it's deemed a self-impoverishment that disqualifies people for care, when it is exactly what we want families to be doing.
I think that's an important point, because right now, families providing care is that link. It saves the government multiple millions of dollars, and it's undervalued and under-recognized. And I see when families are not supported, it just adds to the stress of caregiving, and the whole issue of how to provide that care outside of an institutionalized setting just becomes more acute. So the way it stands right now, Medicaid would rather just have them go to a nursing home, because of the economy of scale. They can pay money and not have to worry about one individual person in the community, whereas most people would rather be in the community and get that care from home if they could get the right support. And I think quality is another issue. I don't think we've done enough to look at what quality measures make sense in a nursing home, and especially looking at palliative care and end-of-life quality measures that I think should be a required discussion on nursing home admission.
Thank you all. I think oftentimes I've seen that when we talk about access to healthcare, that we are quick to point out programs like the Affordable Care Act. We're quick to mention Medicaid, Medicare as being the mechanism for access, right? That if we are at least providing everyone with healthcare, then this question about access is no longer a problem. Can you talk a little bit about, in Black and Brown communities, why even the individuals that do qualify for Medicaid or Medicare are still not getting access to appropriate healthcare?
Well, there are limited doctors who accept Medicaid. You could look at, unless they're going to, say, a federally qualified health clinic or maybe even an academic medical center, that care is very hard to come by. If you look at dental care, it is non-existent. If you look at dermatological care, it is non-existent. So Medicaid gives you some access, but it's limited. It's often of sporadic quality, and you don't get a lot of options. So the reimbursement for Medicaid is barely enough to cover the paperwork for doing the billing. So there are a lot of doctors who just won't accept it. Now, we're an academic medical center, so we see people regardless of their ability to pay. But out in the community, it is a different issue. These are folks that usually have to go to a public clinic, a federally qualified health clinic. There is very little private dollars that will, private health systems that will accept Medicaid. Medicare is different. Medicare does give you access to care. The concern with that is that it's usually a fee-for-service environment, and as you get older, often more medicine is not necessarily better. But because of the way the reimbursement goes for Medicare, you may be getting things you don't really need because that's the only way to get reimbursed. So we have perverse incentives, even though we have these governmental programs. And Medicaid, or as Dr. Dykes mentioned, the dually eligible who are on both Medicaid and Medicare often have a hard time finding quality care.
Thank you, Dr.
I'll give you
Bergman.
another quick little anecdote, if I can, even to add to that, is add other risk factors for disparities. For example, language barriers. And for much of my career, I worked in a private environment, and even as someone who was acutely aware of these disparities and in tune to these, and who had dedicated to eliminating these disparities, if you have a patient that comes into your clinic on Medicaid, and the reimbursement for that clinic visit is lower than the hourly rate that I have to pay the translator to translate for that visit. What happens in environments where there are large populations of, you know, people who have special needs and simply cannot access care? And a lot of the times, from a policy perspective, when doctors go to the Hill, for instance, when I was, you know, working on the Hill, we would have doctors come in and advocate for these issues, and the knee-jerk reaction is that, well, here come the greedy doctors again, you know, looking for more money, looking for higher reimbursement. But that's really not what it's about. It's about access to care for people who need the care. And actually, there's a business case. You know, if these people were provided care, we would actually save money in the system. That's been very, very clearly documented.
Well, that's another example. Nursing homes are supposed to have someone who speaks the language of the patient on every shift. And that may work for Spanish sometimes, but I had a patient once who only spoke Hmong, and they couldn't find anyone, and the Hmong community couldn't provide a 24/7 interpreter. So if the nursing home admitted that person, they would immediately be in violation. But if the person wasn't in a nursing home, they'd be sitting in the hospital costing at a hospital rate, costing more and not getting good care in acute setting. So how would you solve that problem when you have a regulation that says the patient should be able to communicate in their own language on every shift in a nursing home? And yes, that's a wonderful goal, and I agree, because if somebody can't communicate and make their needs known in their own language, they're not going to get good care. But how do we practically roll that out when you have a patient in the hospital taking up an acute care bed that no longer needs to be there, and actually it's detrimental to your health to hang out in a hospital? But if they go to a nursing home, the nursing home could get in trouble for having someone that they can't help communicate. So here's a practical way. How would you solve that problem? There's no legislation that you can turn to that quickly to do that. And so the patient gets transferred to the nursing home and everybody tries their best to communicate. And you may get someone from the Refugee Resettlement Center who can come for a couple of hours here and there, but no one can hang out there 24/7. But you still have to take care of that patient.
It seems to me that there is a huge disconnect between law and practice. There's such a huge disconnect that even you mentioned the regulations in place, but they're just not feasible for the environment that many of these patients are in. Just before we go to the audience's questions, I do want to kind of wrap it all together. We are legal professionals, we are medical professionals in this field, and I think Dr. Dykes brings in a good point that we are well aware of the disparate treatment that our communities face. We all know it, we see it in practice, we see it in our day-to-day careers, and yet sometimes it's really difficult to still address through our careers this disparate impact that our communities face. How would you advise a legal or medical professional entering this field to address this issue, to ensure that medical and legal professionals probably are able to serve our Black and Brown communities? It can be a brief advice.
I have one really practical idea. You know, obviously there are kind of grassroots advocacy things we can do. We talked about that. Obviously, you know, pro bono work, either, you know, litigating examples of obvious abuse or mistreatment. Another thing that we are currently developing and have underway at Upstate, and would love to partner with Syracuse University on this, are medical legal partnerships. And these have been very effective ways at bringing clinical providers and legal providers together for the benefit of patient care. And in some of the models that have been around, they've been very, very successful at addressing some of these social determinants of health, and in doing so, obviously improving health outcomes.
So my suggestion is that you have to have a long view. And there are always so many fires to put out. And we often run around putting out all these fires that we lose focus. But as Dr. Dykes mentioned, this is stuff that's hundreds of years old. So you have to have a long view, and you have to be able to hand this off to other people, and you have to have realistic milestones. Everybody wants this to be gone tomorrow, but that is a long way off. And then I get discouraged when I see who's running, say, the Department of Justice right now, where even if you found something, you know it's not going to go anywhere. If you were going to pursue litigation, that would take so much time, so much money, it's not practical, and it's not going to go anywhere. So I like to see legislation and laws. We can't do anything without laws, but how do we make those laws practical and usable? Years ago, when my husband and I were trying to buy a co-op in New York City and we experienced housing discrimination, we were not allowed to buy this apartment and we knew it was only based on race. We had to sue. It took us more than a year, most of our meager down payment, hauling to court just to get delayed and all these tactics that was hopefully going to discourage us. We finally won, but then we barely had enough money for the down payment for the dang co-op. So yeah, we won, but it was a huge cost. And who really wins? So the burden to pursue these is always on the victim of the problem. And most of the people who are experiencing poor healthcare don't have the energy. Most of the people who are trying to take care of their geriatric patients and still keep their job going and their households running don't have the energy, don't have the time. So it will take other people who have that long focus and have that longevity. I don't know how you finance this because we know everything takes a lot of money. But that's, I think, the beauty of racism is that it is so well structured that it's really hard to break down, and it becomes a self-sustaining system. And if we're just talking about healthcare, that's one thing. We have the same problem with the education system, with the justice system, with the economic system, with the environmental racism. Like, how many more directions do you have to go? And each of those needs that long view. So I really want to ask you as lawyers, how do you do this and what do you do? I can do my little piece in medicine and I take care of one patient and then I got to do it again with another patient because this is a perpetual thing. Sometimes I make a little inroad and then I think, good. And then boom, it hits me again. It's still out there. Kind of like the coronavirus. You think it's gone, but it isn't. So tell me, how do you get a system as perfect as racism? I'm saying this half facetiously, of course, but it has been well established. It was so good that South Africa copied us. We were so good at Jim Crow that they came and took some tips from us and they made apartheid. And look how long apartheid has been broken down. And look where South Africa is. They are nowhere near equity and parity. So I want you as lawyers to tell me, how do you crack a system that is so well entrenched?
Professor Cohn, I know this is a loaded question for you, but I just want your insight on this topic.
It's fair. I called you. So, I mean, I guess my thought here is that we need to think about these issues from a systems point of view as opposed to a rules point of view. So I think often when we're thinking about legislative drafting, for example, we think about what should people be allowed to do and what should they not be allowed to do. And I think that's actually the wrong approach to take. Figure out what you want people to do and create systems that make it easier to do that. And think about the things you do not want people to do and create systems that make it a pain in the tush. And that is part of the reason why I was saying, you know, what can this crowd do, right? And I want to encourage people to bring those hard lawsuits, not because it's fun, not because it's going to be quick, not because it's necessarily even going to do that much for the plaintiff. But if we fail to bring these suits and we just allow things that are illegal to continue, we're allowing the incentives not to be there, right? So remember that a lot of the reason we do enforcement is because we're taking the long view, and we think if this exists on the books and nobody ever tries to enforce it, does it really exist? And so that would be my encouragement for this group, is to think systems as opposed to rules.
Thank you, Professor Cohn. We only have about 2 to 3 more minutes before we have to wrap up, so we may not be able to get to all the questions, but I did want to bring this up because there has been talk about the policies that surround vaccines and how they are distributed and issued. Someone asked, how do the panelists think we can ensure clinical trials are more representative of diverse populations? And how does the medical community overcome the historical mistreatment of African Americans and people of color?
Well, I actually have a grant right now to look at that. This was started because I went to an international conference on all the latest drugs that are in the pipeline for Alzheimer's disease, and there was not one person of color in any of those clinical trials, and this is the entire world. And there was a small cohort of Asians because they did it in Japan. Otherwise, there were no Asians in it either. So I got a grant to look at increasing diversity in clinical trials by creating a community-based research liaison. That's just a little chip in the big, big ocean. I don't think, everybody talks about the Tuskegee study and, you know, when they did all the syphilis for like 40 years and didn't treat Black men. I don't know how many people actually refer to that. I think they have everyday experiences that make them distrust the healthcare system. And right now, especially with the politicization of the whole vaccine, there should not be a vaccine called Operation Warp Speed. That makes every scientific bone in my body ache, because the safety part of this vaccine is usually the part that takes the longest, and anything that's fast makes me worried. So I don't think we're going to ramp up and get a huge amount of Black people or brown people in clinical trials that quickly, unless there's somebody who has a relationship, a trusting relationship with someone in a healthcare system where they feel comfortable enough to do that. And I have concerns about the safety of any vaccine that's being developed in a political environment at warp speed. So.
Thank you, Dr. Brangman. Just quickly for our audience, I want to announce the CLE code is Orange 44. Again, that's Orange 44. All right, we have about 1 more minute, so I want to give anyone the opportunity to say any last minute thoughts before we wrap up.
Again, I just say thank you again for raising this very timely and important topic. Thank you for the invitation, and like so many things in this realm, I hope that this is the beginning of further dialogue and work together on these issues.
And I would second that. And if there is something that we can do in partnership, I am open to that idea. We see most of the older adults in the area with Alzheimer's disease, and our reach goes all the way up to Watertown and down to Binghamton. So we have an interesting mix of rural patients who have issues that parallel a lot of our patients here in the city of Syracuse. So we have quite a diversity of patients who overlap with legal issues in all sorts of ways. And if there are ways that we can start addressing it, I'm open to hearing that.
And I just want to thank Ms. Vargas and Ms. Quinones for organizing this terrific panel. And it's an honor to speak alongside Dr. Brangman and Dr. Dykes. And I look forward to seeing many of the participants here in other panels as part of this alumni weekend.
Thank you, everyone. I will now hand it off to Kristen.
Thank you, Fulvia, and I thank you all, Dr. Bragman, Dr. Dykes, Professor Cohn, Astrid, for the wonderful panel discussion today on such a timely issue. I would also like to take this time to thank the SULA Inclusion Network and the committee that helped plan this event and program today. They're very instrumental in putting all the pieces together. And I also want to thank our sponsors, Hancock and Estabrook and Willadas Law Firm. Thank you. And many thanks to all of you that joined us today for our first day of Law Alumni Weekend. We look forward to celebrating with you the rest of this week, Friday and Saturday. Tonight, we will also host our first College of Law Advocacy Program Alumni Reunion from 7 to 8 p.m. Eastern Time. And then tune into the first round of this year's Mackenzie Hughes competition and watch our students in action. And be sure to follow us on Whova and our website, where you'll get all of the links to our programs for the entire weekend. And we hope that you'll join us for Dean Boyce's State of the College address tomorrow at 9 a.m. Thank you so much.
Thank you again to all our panelists, and we hope this is one of many conversations that need to be had in this environment.
Thanks for organizing this, Fulvia. Bye-bye.
Thank you.
Bye.
Thank
Bye,
you.
everyone.